Welcome and thank you to everyone for joining us for this virtual George Talks with Professor Christine Jenkins. For those of you who don't know me, my name is Professor Bruce Neal and I'm the Executive Director of the George Institute here in Australia. Before we start today, I'd like to begin by acknowledging the traditional custodians of the land upon which we meet today. I'm presenting from Sydney and acknowledge the Gadigal people of the Eora Nation. Pay my respects to elders past, present and emerging, and make a particular welcome to all Aboriginal and Torres Strait Islander people joining the presentation today. So today's talk, I'm thrilled to be joined by Professor Christine Jenkins. Christine is the head of the Respiratory Group at the George Institute for Global Health here in Sydney. She's a senior staff specialist and clinical professor in thoracic medicine at Concord Hospital and professor of respiratory medicine at UNSW Sydney. Christine's been the principal investigator of many large-scale trials in airway disease, and her particular area of research interest has been the clinical management of asthma and chronic obstructive pulmonary disease, with a real focus on assessing practical interventions and drug therapies. She's had major roles in advocacy and leadership for lung health in Australia, and previously chaired the National Asthma Campaign and the Thoracic Society of Australia and New Zealand. And she's currently chair of the Lung Foundation of Australia. Christine's also been at the front line of thinking about how we should deal with the current COVID-19 epidemic. So the format for today's presentation will be a 25-minute, 30-minute talk by Professor Jenkins, and she'll speak about the 2025 bushfire season and also COVID-19 and what that means for our respiratory system. We are going to try and keep a significant amount of time at the end for questions and answers. And I'd encourage you to please submit any of your thoughts or questions through the presentation via the chat box at the bottom. I'll now hand over to Christine. Welcome, and we look very much forward to hearing what you've got to say. Christine.
Thank you very much, Bruce, and thank you everybody for attending. I know that I might be talking to some people who know even a lot more about COVID than I do, but I hope this will be of interest. And I am focusing on what it means for our respiratory system. But because both of these events are so massive, there's no way in which we can't also think about the far more substantial societal implications for both these critical events that have occurred through 2019-20. And I suppose that's the first thing to say, that 2019 was the hottest and driest year on record in Australia. And so the events that lead up to 2020 being such a problematic year for us actually began sometime before. And who knows when the virus really did begin. That's obviously a point of some investigation at the present time. But the circumstances that gave rise to our bushfires were not circumstances that occurred overnight. And this is Cat-Eye Creek, which was very beautiful a couple of years ago, very unspoiled. And I found it quite remarkable to see this photograph on the right-hand side of the bushfires and the ways in which the Wollamai Pine Valley in Wollamai National Park had been preserved. And the people who preserved this tiny strip, this tiny valley, actually put themselves in very precarious circumstances. They were airlifted and dropped into the valley by helicopter. And as the fires raged around, they were really at substantial risk. And in many respects, the bushfire season in Australia has many analogies with what we've subsequently experienced in terms of COVID. And I think that the ways in which the bushfire professionals, the firefighters, the emergency services, the high levels of expertise that are required to preserve something extraordinarily precious like this tiny area of Wollamai National Park. An example also of the sort of sacrifice and the skill and the expertise and the integration of services that have been required for us to try to control the COVID-19 pandemic. So the bushfires in Southeast Australia in November 2019 to March 2020 were absolutely devastating. There were shocking effects on our air quality, but I always felt that for us in the city to be complaining about air quality was really rather feeble compared to the extraordinary loss that people in southern New South Wales and in Victoria and in other parts of New South Wales in the north had gone through. So the air quality index, though, was something that reminded us very much of what had happened in places remote from us, apart from what we could see on our TV screens every day. The air quality index from mid-December in the ACT was at hazardous levels, which is defined as over 200 on 27 days out of a possible 46. So in Sydney, I think we experienced somewhat less of a significant prolonged period of major air pollution, but it was still very substantial over about 3 weeks. In fact, the NASA pictures of the fire plume, the smoke, and the extent of its distribution showed us just how far what had happened on our coast had spread across the world. And in January 2020, NASA estimated, and this was not at the end of the bushfire season by any means, that 306 million tonnes of CO2 had been emitted. So CO2 and carbon monoxide are the major emissions from bushfires. But I'm going to be talking not about those gases, but about the particulates that affect the lungs in particular. And we just got to remember too that the fires had devastating effects on our wildlife, devastating effects on our agricultural land, shocking effects for individuals, for families, for farmers, for people who live in those areas, many of whom lost their houses, and indeed family members and friends. And the shocking effects on our wildlife, which even now, 6 months later, are still looking as if they were devastating in terms of the major impacts on birds and vertebrates in our natural landscape. So the pollutants in bushfire smoke are a complex mix of air pollutants and toxic chemicals. And the particulates that really matter are the tiny particulates in terms of damage to our lungs. And we talk about those as PMs, PM10s and PM2.5s. And that simply defines the size of these tiny particles. And it's the PM2.5s that are particularly concerning over time. It's the PM10s, which are slightly larger, which have irritant effects on our eyes, our nose, cause us to cough, cause the sort of hypersecretion of our airways. But actually, it's the toxic effects of the very tiny particles that are probably more concerning in terms of the long-term damage. We've got to remember also that temperature is a significant problem for cardiorespiratory disease. So increasing temperatures actually irritate the upper respiratory tract, particularly nerve endings called C fibers, which can then, by reflexes which activate the lower respiratory smooth muscle especially, cause spasm in the airways and typically can aggravate asthma and COPD. So people who have chronic airways disease are very vulnerable to both temperature effects and pollutant effects. High temperatures also have a significant effect on the amount of ozone that is available to our airways for inhalation. And ozone is well known to be a powerful irritant, both in normal airways and in people with asthma. This is a narrative review which was done by some of my colleagues in Victoria, and they looked at the effects of airborne particulates in bushfires compared to normal background airborne particulates. And there's been a lot of debate, and in fact it seems always very obvious to people who are in the community broadly, not health professionals, that must be that air pollution is really damaging, and when they see it they feel that it must be damaging their airways. It's somewhat distressing for me to have to say that it's taken us in respiratory medicine a long time to actually document that in great detail. And it still remains an immensely challenging issue. And the reason for that is that it is exceedingly difficult to measure the intensity of exposure, the duration of exposure, and the type of exposure in people as they are actually in a fire zone. For instance, the community fire brigade, all the people who are at the fire front are having variable exposures all the time, depending on their protection, the direction of the wind, the heat, as well as their own respiratory tracts. But it is well known that cardiac disease as well as respiratory disease is significantly influenced by acute exposures. So people who have asthma and COPD have a much higher prevalence of presentation to emergency departments. This has only been able to be shown over cumulative years of bushfires and experiences in multiple different parts of the world. And similarly, ischemic heart disease, either cardiac arrest or acute coronary events are significantly increased after periods of intense bushfire smoke pollution. The interesting thing is it doesn't necessarily occur right at the time. So the intensity of exposure may be greatest at a particular moment in time, but for instance, in relation to cardiac mortality, that occurs 2 to 5 days later. And then the long-term effects of recurrent bushfire smoke exposure, such as occurs in firefighters, or long-term exposures, such as I described even in Canberra over a month or a lengthy period of time when there's continuous, for instance, hazard reduction burning or back burning. These effects are very poorly understood. There have been some effects associated with the birth of low birth weight babies. And there's a recent Australian study that suggests some of the toxins are not things that we would have originally thought to be the case, and that there can be high mercury concentrations. And these impacts are really largely unknown and poorly documented. Animal studies are a very good way to look at this acutely and then chronically, so you can expose small animals like mice, and there are mice models of bushfire smoke exposure, and you can see that acutely and more long term it can impact their capacity to fight respiratory infection. So their airways become inflamed but not necessarily able to manage fighting infection, particularly induced by other organisms. So this is where COVID-19 and the fires may interact. It's potentially possible, at least from animal studies, that we don't handle viruses as well in our respiratory tract when we've been exposed to significant amounts of bushfire smoke. So we get to coronavirus, and I made that very small link, I think it was Andrew Constance who said, after the devastation of the fires in southeastern New South Wales, who would want to make a toast to 2020? And little did we know at that time that he made that comment that we were about to face a global pandemic. So this is the coronavirus, and I show you this only to show you in the top left-hand corner, you can see the tiny viral particles in blue. But in the electron micrograph down here on the left, you can see these tiny corona-like virion particles which line up within the cells. And then when you look at these in detail, you can see that there are different proteins, and these proteins have different names, and they're important for vaccine development. Because they're external, they can actually be targeted in a much more feasible way than is possible for many viruses. So this does mean the coronavirus has some attributes that make a vaccine development more of a possibility for us for the near future. So what are coronaviruses? They're enveloped, non-segmented, positive sense RNA viruses, and they belong to a family that is very broadly distributed in humans and other mammals. And of course, it's some of these other mammals that we have the greatest concern about in relation to how the coronavirus or COVID-19, SARS-CoV-2, actually first was transmitted to humans in China late last year. There have, however, prior to this pandemic, been two severe epidemics which were in fact fatal for the countries in which they occurred, with two other beta coronaviruses. Severe acute respiratory syndrome coronavirus, SARS-1, actually had a very significant mortality rate, 10%, and it particularly affected healthcare workers. The Middle East respiratory syndrome coronavirus, MERS-CoV, mortality rate is even higher, really very high at 37%. And in the last 20 years, these coronaviruses between them have caused more than 10,000 cases. So what we're looking at now is a less lethal virus, but a more contagious virus than those two. Some coronaviruses are causes of common cold. And I'm just going to make this comment about the size of the SARS-CoV-2 virus because I'm going to show you a picture of the lungs in a moment to give you a feel for how many viral particles could end up in your lungs if you were unlucky enough to be exposed. So it's a large virus. It's approximately 0.1 of a micron in diameter. It's spread person to person primarily by respiratory droplets. So if you can imagine a respiratory droplet is a tiny airborne particle that has a tiny bit of water in it, usually of around 5 to 10 microns in diameter. And that tiny droplet can have thousands of virus particles in it. Some people believe, and indeed there's some evidence to suggest that aerosol spread is important as well. So much finer droplets, which we call aerosols, can spread the virus. And it's probably a continuum from the very fine to the more substantial droplet spreads. Droplets are important because they land on surfaces. Aerosols important because it stays suspended in the air. There's some emerging data that, in fact, being previously exposed to coronavirus may enhance your resistance, and that may be why children who are currently exposed to a lot of other coronaviruses, or people in certain parts of Asia, for instance, appear to be less susceptible to this virus. So the lungs. These are the lungs and the heart, and of course if I was a cardiologist I'd show you the heart and not mention the lungs. And one of the things that we respiratory physicians are heartened by in all the disaster of the COVID-19 pandemic is that people actually recognise the lungs are quite important after all. If you were to look at a tiny cross-section of an alveolus, that's your gas exchanging part of your lungs, and there is enough surface area in these alveoli in your two lungs to cover the surface of 2 tennis courts. So it's a huge surface area, and around each of these alveoli run the tiny capillaries. Across this membrane, gas exchange occurs from the air through the alveolar membrane into red blood cells and is then carried oxygenated to the left side of the heart and to the rest of your circulation to keep everything alive and well. And at the same time, we give up carbon dioxide from the blood and that gets exhaled. If you look at the lungs under a microscope, you see this very delicate tissue, which is your alveolar membrane, a whole network of alveolar membranes and the blood vessels that actually accompany them. And then if you were to look at an electron micrograph, which is magnified even higher, you can see that these are like sort of caverns, and these caverns are totally lined with blood vessels, and it's this way we oxygenate and stay alive. But this gives you an idea of the size in relation to those viruses that I mentioned. I said they were 0.1 over a micron across, and this distance here is 100 microns. So you can again imagine how many viruses can get in there. So what do sea turtles have to do with this? Well, they actually have lungs just like ours. They can, however, hold their breath for a very long time when they're sleeping underwater. Unlike us, their lungs are much bigger than their brains. Our lungs are bigger, but certainly not heavier. And unlike us, they can breathe through their rear end, which could be handy, but we can only go one way through the rear end, fortunately. But I was just in Queensland and I quite liked this, which was actually one of the posters up in the Cairns airport. So where sea turtles are much more common in Queensland, they've used a whole lot of images to represent the distances we must keep apart to be safe. And I think this is a really nice localization of information. So let's go to some history. And the Spanish flu, is it like coronavirus? Is it like the pandemic that we're experiencing? Well, it did begin in the Northern Hemisphere. The first wave was a relatively mild disease, but it mutated. And the main wave was devastating. It was so devastating, to give you an idea, that in some US cities, over 10,000 people per week died. Almost a third of the US population became ill. So we look at the US now and think how catastrophic and what a disaster zone that is. But clearly, a Spanish flu was more devastating. Most deaths, unlike COVID-19, occurred in young adults. And indeed, almost all excess deaths occurred in under 60-year-olds. It reduced the mean life expectancy in the US by 10 years. But most people who died from secondary bacterial pneumonia, which is different to COVID-19. Have we been here before? And recently, we have. So this is H1N109 swine flu cases in New York in April, May 2009. And you can see how significant this increase in number of cases is and when the deaths occurred. And you can also see that New York took some significant steps, and sadly, they did not take many of these steps in the early part of the COVID-19 outbreak this year. So COVID-19 did begin also in the Northern Hemisphere. The first wave was highly contagious. It was not a mild disease. So far, although there are many different genotypes within the COVID-19 virus, there's been no mutation to a more lethal form that we've been able to document. In some US cities, unlike in relation to Spanish flu, over 10,000 people a month have died. So I remind you, in New York, over 10,000 people a week were dying with Spanish flu. There have been outbreaks all over the world, and mostly less than 10% of the population becomes ill. But the mortality rates are still very high and very dependent on healthcare services and infrastructure, and also the age demographics of the population and the degree of crowding of the city. Winter is probably important, not necessarily because it favours the virus climatically, but because people live indoors in poorly ventilated houses and in much closer contact. And unlike the flu, although 20 to 40-year-olds are primarily the group that is infected, they are not primarily the group who die. It's primarily older adults. Children are not a reservoir, unlike influenza and rhinovirus. As much as we can tell, they don't even appear to significantly get the virus. Most deaths are due to respiratory failure. The lungs fail, the lung blood vessels become clotted, and the alveolar membranes become so inflamed and swollen, and the alveoli so full of fluid that the lungs can't function. Everyone will be very, very familiar with this map, and I show it only to show you how many, 18.5 million people, confirmed cases. This is confirmed, almost certainly it is the tip of the iceberg, and 700,000 deaths. It's a mammoth impact, and we're only partway through this pandemic. But it's interesting to look, in that previous map I showed you, UK, India, and the US were the top countries affected. But what you can see is a very different pattern of evolution here. So you can see the very high peaks that were reached in the UK in March to May, and then a drop off, and they have so far been successful at keeping this curve flat through their summer months as they open up again. But they're still only on level 2. We've got to remember they have not opened up normally. India is on a very steep part of the curve, and the USA had a peak, which they started to control, and then they've had another much worse peak, and almost certainly are going to continue to have very, very high peaks. We can look at our own stats by comparison, and the best way to compare this is not just by the numbers affected because of our different populations, but more by our case fatality rate and by deaths per 100,000 of population. And so what you can see here is comparing us to the United Kingdom. We are very much further ahead in terms of low case fatality rates and also very low deaths per 100,000. So the public health responses to COVID-19 are critically important in determining how impactful this virus has been in the community. But it is a virus like no other, and just to simply think of it as a flu-like illness or as something that resembles epidemics we have seen before is completely erroneous. The major predisposing factors for this virus in terms of critical outcomes are age, increasing obesity, diabetes, hypertension, cardiovascular disease, and being male rather than female. So females have 20% less prevalence of severe outcomes from COVID-19. Non-survivors tend to be older, mostly die from respiratory failure. Many have multi-organ damage, and in fact, only around 30% of people have a cytokine storm, which is much talked about, but not actually the main mechanism of death. There are some surprises, and we still don't fully know, but it seems that people with airways disease are less likely to have a critical outcome from this disease and even possibly to acquire it. And that might be behavioural. It might simply be that they have lung disease and they know that having an additional insult like COVID-19 could be immensely damaging for them, and perhaps they're just staying away. But we've yet to fully understand the things that might mean that people have a reduced risk of having a critical outcome apart from being younger. These are New South Wales data, and I show them only to show you a comparison between New South Wales and Victoria. And what you can see here is that in New South Wales, we had our big peak at the beginning, and then we flattened really, really well. And even now, though we are having significant increase compared to May, June, it still is a very, very flat curve, and fortunately under very good control, and the track and trace in our state has really been working extremely effectively, and we are very, very fortunate. This is Victoria by comparison, and I just show you this to show you how different their curve looks. This was their first peak, then they flattened off just as we did, and now they have this devastating increase, and 725 new cases since yesterday, and they are predicting they will probably reach 1,000 cases a day before they start to drop. And you might appreciate this if you can see that of the 725 since yesterday, 561 of those are still under investigation. In other words, they do not know the index case or the means of contact by which those people became PCR positive. So if you imagine this repeating itself day after day, you can appreciate the size of the public health challenge. These are New South Wales data again, just to show you again the predominance of cases in 20 to 40-year-olds. So it's not 60-plus-year-olds who are the predominant cases, but it is 60-plus-year-olds who are dying from COVID-19. And here again, you see this very prominent male increase over females in terms of deaths, and it's the same for critical outcomes such as hospitalisation and ICU admission. So let's go to viral transmission. These are early data from China, and I just want to show you this to show you that people can carry and secrete the virus over significant periods of time. And these are clinical cases rated red for severe, black for moderate, and blue for just being a contact and not necessarily symptomatic. And what you can see here is that the blue data still show very high titers of virus in nasal swabs, and in throat swabs the same. and also that there is some variability, but that just because you have very severe disease doesn't necessarily mean that you have the highest titers. And there are some days on which people with either milder disease or not even symptomatic have higher viral titers. And this study very recently, a preprint, not yet peer-reviewed, aimed to look at the viral load dynamics and how this relates to clinical illness. And what they showed was that the mean duration of SARS-CoV-2 shedding was positively associated with age, so longer shedding with older age. No study to date has detected live virus beyond day 9. So even though virus is shed over many, many days, often you will hear that people have shed virus for 14 days, 21 days, 28 days. There is evidence of viral shedding up to 60 days in some case reports. This is not viable virus. It will not replicate, and it is not therefore likely to cause infection if somebody encounters it, because it's not viable and therefore is not associated with being contagious. But because shedding is prolonged and because there's high titers in week 1 of the illness and an early peak that occurs at symptom onset, probably also for the day or 2 beforehand, from several studies we're now seeing this, through to day 5 of illness. These are the critical times, and of course some of this is a silent period, the period before someone has symptoms. So we must remember, despite all the terrible stories we're hearing, that 80% of PCR positive cases are mild. They have mild clinical illness. This will come and go depending on how much testing we're doing, this particular fraction, 80%, but it is significant that most people have mild disease. When entire populations are tested, about 50% of people who test positive are asymptomatic at the time, but a significant proportion of those become positive, become clinically symptomatic very soon after. The North American data tell us that of those who are symptomatic and positive, about 10% end up being hospitalised. 25% of admitted patients require intensive care, so this is of admitted patients. This was from New York, and depending on the hospital you're in and the infrastructure and all the available expertise, the mortality rate can be up to 50%. For those requiring admission, there seems to be a sort of an early phase where people are very symptomatic but don't necessarily progress to respiratory failure, and then often will suddenly deteriorate and require intensive care admission very rapidly. In the first studies we saw published from China, what we saw was that a much younger cohort, which is a little bit hard to explain in many respects now that we see that it's older people predominantly who have critical outcomes from COVID. But as you know, a 30-year-old died in Victoria yesterday, and nobody is immune from death or a critical outcome with this disease. But we still don't really know what determines that in younger people. And it will be vital to know this even in older people, because there are clearly older people who do not necessarily suffer a catastrophic outcome, despite having some of the comorbidities I mentioned. There are certain criteria that we can look at which help us to know whether or not COVID-19 is the likely diagnosis when someone presents with pneumonia, although at the moment, of course, we suspect it in anybody who has respiratory symptoms, who is clinically unwell. These are New York data, and they're only very recently published, and again, they reinforce the fact that being older significantly, markedly increases the risk of death from COVID-19. Being male, 1.5 times more likely to die in New York if you were admitted and had a severe outcome. Having coronary artery disease, having active cancer were also associated. Having diabetes is definitely associated, and being obese is definitely associated with an increased risk of a worse outcome. But interestingly, even in New York, hospitals varied considerably in the risk-adjusted proportion of people who died, and that range was massive and very concerning. that healthcare services can so determine your outcome if you have this disease. These are just some radiographs that show you the ways in which COVID-19 can affect the lungs. And indeed, the Chinese first said that we could use CT scans to diagnose it. And the CT scan features are unique to COVID, and in many respects, most of us now could eyeball a CT scan and say, in the clinical context, that's definitely COVID. But there are scores that enable us also to tell whether or not somebody has the kind of COVID-19 disease that is going to have a bad outcome. And this is just one which has been recently published. And almost certainly these scores are going to help clinicians triage patients to the ward, to ICU, to a high dependency environment, or to rapid respiratory support. And so that's the value of the massive raft of publications that has come out so quickly in relation to COVID-19, that we can now develop these scores that enable clinicians in the emergency department to determine who is most at risk of having a critical outcome from this disease and who is going to require respiratory support. We now have some evidence that there are treatments that can make a difference. The antiviral treatments, remdesivir is one, can slightly shorten the duration of the illness. However, more importantly, in this UK study, this was an adaptive trial, this was a pragmatic trial, and it's really exemplary that they were able to conduct this randomized trial. And they have not yet published. The peer review paper has not been published, so there still must be a few reservations about this finding. But of all the treatments, dexamethasone reduced the 28-day mortality rate by 17%. Now, this is a massive mortality reduction by any standards in a drug trial. It's important because this dexamethasone dose is low dose, it is affordable, it's a very cheap drug, it is very widely available, and in this study it was given low dose orally or intravenously for only 10 days. So a very accessible medication that can reduce the risk of dying from COVID-19. But it only did it in patients who required oxygen. So they found no evidence of benefit in people who were more mildly unwell, even those in hospital who didn't need oxygen. They had good follow-up and many good aspects to this trial. And you see these data. These are the people who required oxygen, and you can see the reduced risk of death in those who required oxygen and received dexamethasone. And you can see this in the people who required mechanical ventilation. So the greatest benefit of this drug was seen in the sickest patients in intensive care requiring supportive ventilation. Now I just want to get briefly to some issues around prevention, and then we can have time for questions. And this is a systematic review that looked at physical distancing and its impact on viral transmission, as well as face masks and eye protection. And they used data from the WHO databases for both SARS-CoV-2 and also for SARS-1 and MERS. So this is really the first systematic review published for these coronaviruses, looking at the impacts of physical distancing and mask use. And they showed a dramatic reduction in probability of acquiring COVID or SARS-CoV-2 with physical distancing greater than 1 metre compared to no physical distancing. Protection was increased as the distance was lengthened. They also showed that face mask use could result in a large reduction in the risk of infection, with an odds ratio of 0.15 if you were using a face mask. That's an 85% reduction, and an even stronger benefit from N95 masks in healthcare settings. And eye protection similarly had a dramatic effect, about an 80% reduction in acquisition of infection. And you can see this here. This is the comparison group. In this case, shorter distance, no face mask, no eye protection, compared to the intervention group, and you can see the risk of infection in each of these. 3.1 with a face mask in the intervention group compared to 17% acquiring the infection with no face mask. So a very impressive effects. And here you see this for distance. So imagine this is the baseline risk of infection at 0 distance, so almost face to face with the person carrying the virus, through to 1 metre, significant drop, 1.5 metres, 2 metres, 3 metres. So for every additional 1 metre of separation, you more than double your chance of not getting the virus. So masks, to do or not to do. I make a reference to Shakespeare because Shakespeare was born in the year that the plague arrived in Stratford. And in the year that Shakespeare was born, 200 people died in Stratford from the plague. Shakespeare was self-isolating when he wrote King Lear in 1603. And in that year, people died in London at a greater rate than they have died from COVID-19. London experienced over 3,000 deaths a week from the plague, and that was with a population of 200,000 in total. So the Shakespeare illusion and masks is not entirely wasted, I hope, except that this is not the kind of mask we should be wearing. Masks and respirators reduce the risk of infection very substantially. For the community and households, cloth masks are effective. They should be made of water-resistant fabric, they should be multiple layered, and they need to fit properly. They can be washed every day, and they will be really important when lockdown is eased, if we ever end up in that unfortunate situation ourselves in New South Wales, and certainly for the Victorians. So what do you need to know? If you're using a surgical mask and you're a healthcare worker, there are some very, very strict rules. Masks must be made as closely fitting as possible. That means they're going to be uncomfortable. If they become wet, they should be changed. When you touch the front of the mask, you contaminate it and it's no longer useful to you or to the person you're trying to protect by wearing it. You need to therefore perform hand hygiene as well as use a mask. High particulate respirators are very good for healthcare workers and greatly help, but there is actually only a small increase in percentage benefit above a surgical mask alone. And vaccines. Everyone's talking and has been talking about a vaccine. These are just some of the headline papers that have been published in the last 2 weeks. You'll see the dates on these. The majority of them are from the 20th of July or mid-July onwards. They're very different types of vaccine. They've been trialled in humans, they've been trialled in macaque monkeys, and they show immense potential. One of the things that the vaccinologists are excited about is that these vaccines stimulate not just antibody production, but also T-cell immune responses. And so it may be that we have a sort of double response to these vaccines if they prove to be safe as well as efficacious. And some of them are now entering phase 3 clinical trials, which is very exciting. So I finish just by saying that I think you will all appreciate this is the fight of our lives. I think there are some positive outcomes. It's not all utter doom and gloom, but it is a devastating event, and hopefully it is truly a 1 in 100 year event, but nobody knows that. Many of you will have read this book by Jared Diamond, in which he argues that it's not just good by good measures that people didn't end up getting devastating effects, but also by geography. And I think we are fortunate in Australia, and we have to be thankful for the fact that we are a wide brown land after all, that we do live mostly not in highly crowded circumstances, and mostly in environments where we are not impoverished and where we are not so severely impacted by crowding that this virus is going to spread like wildfire. And I think there are some real positives for people involved in science. I think very positively that the community more widely respects what's being achieved by the scientists, by clinicians, by the public health expertise that we have available to us. And I think we're immensely fortunate that our politicians are listening to that advice, and we've come to appreciate the role of good government and not just politics and the argy-bargy that goes on so often that we have to listen to has been replaced by a real attempt to keep our society safe. So I think these are things that we can really be pleased about, and although I've talked about the devastating effects for some people, and particularly for people who develop COVID-19, the lung disease from SARS-2-CoV, I think that there is some hope on the horizon, and it's hopefully going to also lead us to think more carefully about the things we value in the world around us. Thanks very much, Bruce.
Thanks very much to you, Christine. That's a tour de force review of all things COVID and a little bit about bushfires too. I think when we first thought about this talk a long time ago, we were thinking more about bushfires, but I think quite rightly the focus has been on COVID, and that's certainly where most of the questions have come in so far. So look, without further ado, I am going to just fire away into some of these questions. We had a question about masks and how often you should use them before you wash them or throw them away. And I think you've probably mostly covered that. But another question was in regard to your comments about aerosol transmission. Do masks cover off on aerosol transmission in the same way that they do in terms of droplet transmission? And is there anything else we need to be doing to try and prevent that aerosol transmission?
Aerosol transmission is still not really fully understood in terms of the extent to which the viral particles that remain in the air, so people have documented viral particles or virus staying around in the atmosphere if it's not highly windy, etc., for sort of 18 to 20 hours after infected people have been in a room. But what's not known is how long the virus remains viable. So the fact that it can be detected, as I mentioned, doesn't mean it's going to replicate. It's probably the first couple of hours after exposure that it really matters, or after an infected person has been there. In terms of masks, surgical masks are not effective against those ultrafine aerosol particles because you're entraining air into the side of the mask. So a surgical mask is not a perfect fit, but I mentioned, you know, it's still important to have it fitting. Don't let it drop down below your nose. Don't let it sort of half fall off your face. And N95s are better, but an N95 to work, it's a beneficial mask only if you fit it properly, and fitting an N95 properly is really a skill business. In fact, we health professionals had to be taught how to do it, and then you must keep it on, and it's uncomfortable, and it must be kept on and sealed for a couple of hours, and usually then changed. Okay,
thank you. Thanks for that one. The next question relates to some of the comments you made about immunity. And I guess the sort of the million-dollar question is, if you've had it once, can you get it again? And is there any evidence out there about that at the moment?
The evidence is not conclusive, Bruce. I'd have to say that I listened to a New England journal. The editors, as many people will know, have a weekly podcast, and it's really fascinating to listen to. And the one I listened to this week still made that comment that we really don't know if people can get reactivated disease, or whether they're re-exposed and they have not got natural immunity that lasts. And in fact, that's one of the key points around vaccine development. One of the things about vaccine development is that some of those papers show that the amount of antibody that is produced by what they think is a dose approximately equal to the one we would have is actually higher than we get with natural immunity, or people have had measured with their natural immunity after having COVID-19. But what we don't know is what is the desirable level, and also how rapidly does that peter out. And merely having antibodies, there are different types of antibodies, and many people think that those antibodies wane quite quickly. So the answer is almost certainly yes, you can get it again, but we actually don't know. What we do know is older people don't produce those antibodies as well. And even to the vaccines already, that's been shown. And the vaccine trials so far have not included people over, I think one of the most recent trials is people up to 55 were included. So there's still a lot to be learned about this older, very vulnerable population that doesn't produce antibodies as well either.
So there have been a number of questions come in regard to vaccines, and my pretty limited knowledge of immunology from when I was back in medical school, I was sort of somewhat discouraged by what I saw in terms of some of the antibody levels in the human studies that have reported them. And I was also somewhat discouraged by the observation that it seemed to be that children were catching multiple different sort of similar viruses on sort of regular occasions. Is that a reasonable interpretation? And does that mean that we need to be cautious about our expectations with vaccines? Or are you pretty hopeful that we will come up with a vaccine in a short time frame?
Going to the short time frame, how short would that be? I don't think we're going to be looking at a vaccine before the end of this year. It's very likely it will be next year. It's conceivable it could be the end of this year, but that's sort of interval, and by that stage we won't really know the safety data that we really need to know. So I think that we could have something efficacious but not know how safe it is, because it won't have been given to a wider range of people. The issue around antibody levels, I have heard it said, and again, my immunology is only a minuscule amount more than yours, Bruce, that in fact it is very encouraging that these T-cell responses are also being stimulated, because we don't actually know what the target level of antibody is that we need. So more importantly, our T-cells, we have memory cells that can actually potentially ramp up as soon as they're re-exposed to the virus. So it may well be that these cell-mediated as well as humoral responses it's all important, and it's not just one type of thing, an antibody or not, that's going to protect us.
Okay. Another question that's come in related to the very high mortality rates that we're seeing in patients who end up in ICU. How would those mortality rates compare to patients that end up in ICU for other reasons, such as, I guess, post-cardiac surgery or major trauma? Do you have a sense of that?
I do. I mean, the outcomes from, it depends what you do have and how much multi-organ failure there is. But if you have a critical pneumonia, for instance, a non-COVID pneumonia, and you require ventilation, when you're admitted to ICU for that reason, you have only, your chances of survival, your mortality rate is still around 30%. So, COVID is probably twice that, but it's not an order of magnitude more. Yeah.
But so this is clearly, if you end up in ICU, you're doing badly, even compared to a lot of other very sick people who end up in ICU, is what you're saying.
If you require ventilation for respiratory failure, yes.
Okay.
Yes.
There's another question just coming about vaccines, and it says, for us 60-year-olds, and I'd just like to exclude myself from that bracket for another few years. What do you think the likelihood of the vaccines being effective is? I mean, you've sort of alluded to this. Do you think it's going to be that they're going to be less effective in the old people because of the different sort of immune responses we see, or and do you know, are there analogies to other vaccines in that regard?
Yes, I think it is likely to be less effective in us, but we're going to be helped by the rest of the population being vaccinated. So this is how we could develop our herd immunity, not by all of us acquiring the infection, but by as many of us being vaccinated as possible. And I'd just like to say something there, Bruce. Influenza vaccine doesn't elicit the same responses in older people, in 60-year-olds plus, as it does in young people. Nothing like, in fact. And yet it is a highly effective vaccination. And I think we could find the same in relation to individuals. We won't have, the older people won't have as high antibody levels, But younger people who you can see are getting the virus and transmitting the virus so actively in our community, they, if they get vaccinated, will then help protect the older people in the population. What I want to say about that is that's why this issue around safety in relation to our vaccines for COVID is so important. If, for instance, in the haste to get a vaccine available to the rest of the world, a vaccine is rolled out ahead of time and there is a catastrophic safety adverse event, this will put people off vaccination massively. It fuels the fire of the anti-vaxxers. We absolutely do not want that. Already there are very high levels, not necessarily in our community, but in Europe and North America. I've seen some devastating anti-vaccination statistics that suggest that 30% plus of people would not have a vaccination. So I think we must really try to understand that the care over rolling this vaccine out is going to be crucial to maintain the community's confidence in vaccination.
Yeah. And now, look, I think that's a really good point. And just so you know, I've had my flu vaccine to help you older guys out this year.
Yes, yes. I just finished being in the 60s.
Someone's got another question about T-cell response from vaccines versus the antibody response. Have you got a very brief response to that in terms of how those two augment each other, Christine?
Well, I guess, I mean, we produce antibody from our B lymphocytes, and our T lymphocytes are very important in augmenting a number of anti-inflammatory responses we have to deal with organisms. And lymphocytes retain memory and are able to both recognize an antigen and deal with it. And so having, and they can produce antibody as well. So we've got a sort of a dual benefit if the lymphocyte is involved in immunity in response to the vaccination, both in terms of stimulating its response, its non-antibody responses, as well as antibody-based responses.
Okay. Probably the last question now that is actually a question from me. You showed the data from New South Wales and Victoria, and it is tragically and devastatingly different at the moment. What do you think is the likelihood that we in New South Wales, or indeed our colleagues in the other states and territories around Australia, are going to suffer a similar problem to that being experienced in Victoria over the next 6 months?
You know, Bruce, I think it's possible that we will not suffer it. I know that borders are leaky, porous. We've got to have freight coming in and out of our country. People have to come and go at very high levels in government from time to time. There are significant ongoing risks, there's no question. But I think Victoria is such a salutary experience, and I'm hoping that people will understand the consequences of such a devastating event as has happened in Victoria, as well as the sort of care that can be taken to prevent it. And so I think community education is still a key thing. And I really, you know, I think we've all got to just work hard to help everyone understand this is for all of us. It's every one of us has to take care here. And if we do, we could avoid what's happened in Victoria.
Okay, well, look, that's a sort of positive note, and so maybe that's a good place to end. Once again, I'd like to thank all of you who joined for this session. I'd like to particularly thank Christine for taking the time to put together a really interesting, really contemporary presentation. And I'd also just like to thank Matt and Heidi behind the scenes who have put together all the logistics for this and make sure that everyone got an invitation. So have a great day, everyone. Thanks again for coming, and we'll look forward to seeing you for our next George Talks. Bye.
Thanks, Bruce.